This poster presents the following case. Of a 38-year-old man with history of travel from Cuba through Central America who presented with a 2-month history of left-sided facial swelling accompanied by itching and burning that started as a bump that appeared similar to a pimple, as seen in Figure 1. He applied warm water and vinegar and an ointment called pomada de la vaca mastiti to the area without improvement. Initially, he visited a hospital for a sinus, facial, and maxillary CT and a neck CT that indicated cellulitis with minimal reactive adenopathy. He was treated with IV vancomycin and levofloxacin and discharged on doxycycline without improvement. A month later, he visited the hospital and an oral and maxillofacial surgical team performed a shave biopsy of the lesion. Acid-fast bacillus stain, periodic acid shift stain, Warthin stari stain, and von Cosa were negative for organisms. Leishmaniasis species was not identified on pathology. Infectious disease workup showed normal immunologic markers for quantiferin TB gold, coccidioides, histoplasma, aspergillus, blastomyces, Bartonella henselae, Rocky Mountain spotted fever, and rickettsia typhi. Leukemia and lymphoma evaluation showed normal cell populations. Aerobic bacterial gram stain showed no organisms or white blood cells. HSV was not isolated on culture. RPR was non-reactive. Normal serum protein electrophoresis was demonstrated. Skin aerobic culture grew E. coli susceptible to numerous beta-lactam antibiotics, aminoglycosides, tetracyclines, and trimethoprim sulfa. A Leishmania PCR mini exon DNA analysis detected Leishmania guyanensis species complex. He was treated as an outpatient with fluconazole 200 milligrams daily for 42 days. The patient had improvement and used zinc oxide impregnated gauze at night to keep the scab soft. A Leishmania PCR mini exon DNA analysis that detects Leishmania guyanensis species complex in a patient with a facial ulceration and a history of traveling through South America is consistent with a diagnosis of cutaneous leishmaniasis. Leishmania derives its name from Scottish pathologist Lieutenant General Sir William Boog Leishman. Sir Leishman discovered the parasite in the post-mortem spleen of a British soldier stationed at a town called Dum Dum near Calcutta in India. Bites from sandflies of the subgenera Phlebotomus and Lutzomia can lead to leishmaniasis. The geographical distribution of leishmaniasis matches the distribution of sandfly habitats, forests, rainforests, and agricultural fields close to forests. In Bolivia, increases in urban transmission of the disease were noted as early as 2007. Manifestations of leishmaniasis include cutaneous, mucocutaneous, and visceral. The most common form is cutaneous leishmaniasis. Leishmaniasis may result from New World or Old World species. The New World has greater diversity of species than the Old World. American leishmaniasis may be called American tegumentary leishmaniasis or spondia. The immunological control of leishmaniasis is STAT4 dependent. Host immunologic response to leishmaniasis may be downregulated by RNA viruses that infect the Leishmania parasite. The gold standard for diagnosis of leishmaniasis is PCR. In our patient, a Leishmania PCR mini exon DNA confirmed our diagnosis. Other strategies include a Montenegro or leishmaniasis skin test, indirect immunofluorescence assay, or ELISA. A direct exam with light microscopy has a low sensitivity of 15 to 30%. Generally, cutaneous leishmaniasis will follow a similar presentation that may aid in clinical identification of the condition. After 2 weeks to 3 months of incubation, an erythematous papule or nodule may appear in conjunction with lymph node enlargement. The initial papule or nodule may lead to an ulceration that may have central crusting. Important differential diagnoses include fungal, such as aspergillosis and blastomycosis, neoplastic, such as basal cell carcinoma and B-cell cutaneous lymphoma, and infectious causes such as cellulitis or viral, such as herpes viruses. The treatment of choice for cutaneous leishmaniasis is pentavalent antimonials, 10 to 20 milligrams per kilogram per day. Other treatments for cutaneous leishmaniasis include pentamidine, 2 to 4 milligrams per kilogram per day on alternate days with 2 to 4 applications, amphotericin B with a total dose of 18 milligrams per kilogram, miltefosine with a dose of 50 milligrams per day for 28 days, sodium stibogluconate, meglumine antimonate are other treatments. Another treatment for New World leishmaniasis includes paramycin with or without gentamicin, and cutaneous leishmaniasis sometimes will ultimately self-cure. Our patient was treated with outpatient fluconazole 200 milligrams daily for 42 days with excellent results, and he used that zinc oxide impregnated gauze to keep the scab soft. This case demonstrates the importance of having a broad, geographically informed differential diagnosis for patients who have an extensive travel history.